Hope we don't lose everything.
He's working on it. There you go.
All right, so we'll go through real quick on the go across first. So number 3 across is tidal erection. 4 across is febrile. 8 across is malignant. 9 across is the hypothalamus. 11 across is the 4 W's. 12 across is the NSAIDs. Down, 1 down is fever. Number 2 down is inflammation. 5 down is IV therapy. 6 down is hypothermia.
Took it with the girl.
7 down is antipyretic. And 10 down is sweating. Okay? All right, so now let's go to our scenarios where we're going to do the same thing we always have. I'm going to put one up there, let you pull off all the data. So write it on a piece of paper, and then circle, highlight, or underline, somehow indicate anything that is abnormal, especially if it pertains to a temperature concern. And then based on the risk factors and the signs and symptoms, tell me what's going on.
Ms. Martinez, are you the only one here today?
He's going over it right
I mean, sir, like, here.
Okay, are we ready?
In classes?
now. No.
So the first piece of information is the location of the patient, which is the patient's in the recovery room. Okay, so that tells us the context of where all this is happening. They're restless, agitated, their skin is flushed, warm, and dry, pulse is weak, respiration shallow, and the patient is stiff. Hypertonic means the muscles have an increased muscle tone, so they you can't move them very easy. And then that's their vital signs. So are they hypothermic? No, so that rules out the first one. And now they're one of the other 4. So based on the risk factors, what has a person just experienced when they go to the recovery room? That is a risk factor for one of our 4 problems. Anesthesia, right? So they're recovering from surgery and anesthesia. So which was the 4 of our heat problems or temperature problems that was too hot based on anesthesia? Malignant hyperthermia. So what would our interventions be for this individual? Oxygen. Start cooling them off, so our cooling measures. But we have to do something to stop the heat production. What was that? The IV what? Yeah, the dantrolene. Very good. Okay? Here's our next one. Somebody say something about heat stroke?
Yeah, that could have been heat stroke too. But
Which one? The one we just did?
yeah, all those same signs are on heat stroke.
Well, what separates them is the context.
Right, he's in a recovery room, so that.
Right. So they're not working hard, they're not generating heat. So no, that can't be a heat stroke. Heat stroke happens as a result of a hot, humid environment. Remember, that's our risk factor. Somebody who hasn't acclimated to a hot, humid environment, and because of their physical exertion in that environment, they deplete their fluid and electrolytes. When you look at that person's blood pressure, is their fluid and electrolytes depleted? No, they're not hypovolemic. Okay? But thank you for making that comment. So remember, the way we distinguish things is what we call compare and contrast. We compare and contrast not just the signs and symptoms, but the risk factors and the context. Those are vital. Okay, on this one, our context is they come to ER after having fallen out of a boat while fishing. So that means they were in the water. And then look at the context. It's early spring. What's the temperature of the water? It's cold. Okay, the next piece of data is you smell alcohol on the breath of both the patient and the two buddies. The patient has what would we call that sentence if we summarize it? Decreased level of consciousness, skin is pale, cold, capillary refill is decreased on all four extremities, piloerection. When does piloerection occur? When you're cold and you're trying to raise your body temperature. And then look at what his body temperature is, and then look at what else has slowed down. Okay, so what do we have? Too hot or too cold? Too cold. So our one too cold problem is hypothermia. And remember, water conducts heat away from the body very quickly if it is colder than the body's temperature. And so we don't typically have 98-degree water during the springtime unless you're fishing in the hot springs. And that doesn't happen because fish don't live there. Okay? So what would we do for this person? Ooh, what are we going to do first, though? We're going to remove his wet clothing, but we got to put him on that cardiac monitor, remember? Because we got to make sure that while we're drying him and moving him around, that we don't elicit that ventricular fibrillation problem. Okay? And then we're going to do those active rewarming. Can we provide this person oral fluids as an option? No, we got to get him more alert, right? So we have to use some of those more invasive ones, perhaps to get him warm. Now, with him only being 95 degrees, and it doesn't indicate to us where this occurs, so we're presuming it's here in Oklahoma. So we're not talking about somebody who fell into ice water necessarily, but just water that was probably 50 to 70 degrees. Okay, so bottom line is we probably won't have to go to anything that invasive, but hot blankets and maybe a bear hugger and possibly warm IV fluids, and that may be all that's required for it. Absolutely, the ABCs are part of that. Remember, the cardiac monitor is going to see the circulation side of that. So airway and breathing, we know he has both already because we have a respiratory rate of 12. So we've already assessed his ABCs by the time we've got his vital signs. Okay? Close. So that doesn't mean we have to take them completely off to put him on the monitor. We just have to cut the front or unbutton the front, dry the chest, and slap them on. And then we can proceed with the rest of it. Okay?
Mr. Mayor,
Yes, please.
how would you keep those IV fluids warm in the hospital environment if the hospital is typically cold?
Well, the hospital environment will typically be climate controlled, and so typically that's either low 70s to mid 70s is pretty common in an ER context. Okay, so that is obviously colder than the body. But when we pull those IV fluids out of the warmer, they will stay warm long enough to infuse for a while before they ever cool off to that temperature. Kind of like when you pull a pan of boiling water or hot water off of the stove, it stays warm for a while. And the same way is true with those IV fluids. Okay? All right, let's do another one. Let's read number 3 there. Do the same thing. Create your list, circle your abnormals. Okay, let's take a look at this one. So our data includes a 72-year-old patient. So we have an elderly client. He had been working in the garden all morning without stopping for something to drink. So again, we don't know the time of year, but we're presuming that this is spring or summertime, so that chances are he did some sweating while he was out there, but he's not replenishing it, except his wife says he primarily drinks hot tea. Remember, warm or hot fluids, just like smoking a cigarette, produce heat, and they add heat to the body by that heat transfer being conducted into the blood vessels that run along the GI tract. So not only was he replenishing fluids with a hot fluid, he's also replenishing with one that has caffeine, meaning the vasodilatation that he would normally benefit from to help keep him cool is now being constricted by what he's drinking. Notice he has a headache, he has that generalized weakness, he's pale, he's moist, but his turgor is diminished. And then notice in this context how his blood pressure is low, but his pulse is high. What fluid electrolyte problem does that represent? Hypovolemia. And so hypovolemia, in the context of somebody working outside all day, produces these signs and symptoms. And what's the nursing problem? Heat exhaustion. Do we see any indication of neurological changes? Not yet. Do we see that marked temperature elevation that goes with the heat stroke? Not yet. Do we still indicate that he has some fluid electrolytes available? If so, where do we see them? His skin is still moist. He hasn't completely stopped sweating yet. Okay? So his wife was good to bring him in. So what would we do for that person?
Give them cold fluids.
Okay, so he's still alert enough that we may be able to meet his need with just some fluid electrolytes in an oral form. But what else could we do? A fan, put him in a cool environment, put him on bed rest as far as while he's there in ER, let's not have him walk into the bathroom or whatever and generate more body heat. You might have to pull off some of his clothes. A lot of the time the elderly like to work outside in long sleeves and long pants, unlike a younger person who might use something cooler to wear. So we might need to put him in a hospital gown, turn the fan on for him, and and try to get his body temperature back while we provide those fluid electrolytes for him. A wet washcloth might feel good to him, but without evaporation to that wet washcloth, it doesn't do anything to really change his body temperature. It doesn't do much, let me put that. It's more of a comfort measure. Yeah. Now, when we talk about the heat stroke person, that's a little different because we do something more aggressive than just a washcloth. All right, so let's do this one. Number 4. He probably wouldn't need oxygen. Yeah.
I just need another sign decisions really good, because on contact message will get asked, someone's having a stroke, what sign decisions will go along with it, or what interventions will go along with that.
Okay, so this individual arrives by ambulance after he's had his first seizure while out in the field hauling hay. His family says he's never had a seizure before, so this is his first episode. Currently, he is lethargic. What's another phrase we used a while ago to describe that? A decreased level of consciousness. However, he is still arousable. His skin is flushed, hot, and dry. His left grip and left leg are weak, and then those are his vital signs. Now, at first, when you look at that blood pressure, you think, well, he has a normal blood pressure. But remember our phrase, raise head of bed unless dead or appears to be so. So somebody with a decreased level of consciousness is probably laying flat. So we have a blood pressure of 110/66, but look at what his pulse has to do to maintain it even while laying flat. He's at 110. And then we have a positive tilt test. So what does the elevated pulse, blood pressure, or the positive tilt test, what does that tell us about his fluid electrolyte status? Hypovolemic, right? So he's hypovolemic, flushed, hot, and dry. He's been out hauling hay, had his first seizure, and now he can't use that left arm grip, left hand, or left leg well. What is this person's nursing problem? Heat stroke. He has the neurological changes now that go with his heat-related problem. So in this situation, what do we do for him? What's our nursing actions?
Just go a cold, grab them, blanket or whatever else.
Yeah, we don't want to use a blanket. We want to wrap him in a sheet, something thin, so that when we turn a fan across him, it will evaporate the moisture from the sheet, carrying away heat with it. Okay? We could use the cooling blanket or the cooling device as well, and it will dissipate the body heat also. Okay? What else could we do? Is there anything else? Yeah, we need him on a monitor. Something else?
IV fluids.
IV fluids, absolutely. And most likely, when we looked at his lab work, we need to replace some electrolytes with it, because remember, with all that sweating, those are electrolytes as well. All right. Take a few moments to go through that one. Just room temperature IV fluids, because remember, those are typically 20 to 30 degrees cooler than his body anyway. His normal body temperature. So.
13, 14, 14, 15. Hey, listen, well, Miss Martinez, I'm just, it's all right. On the blueprint, it says we have 51 questions. When you add them all up, we're just counting them. It's 13 for death and dying, it says. 13 for.
Okay, so this person presents himself to the clinic. He has an injury on his left lower leg that happened 2 days ago. So there's been some time since the injury occurred. And when you look at his cut, it has redness, heat, and swelling. And this tells you the location. And you see that the cut itself is 3 inches long. He's held it together with Band-Aids, but he has pain, redness, heat, swelling, and difficulty flexing his left foot. How many signs or symptoms does he have of what problem that did we talk about? Inflammation is how many of those signs or symptoms? He has 5, that is correct. There's only 5 and he has all 5. Okay, so he has an inflamed wound for sure, but look at this number right here. Is this just inflammation? He now has infection as well, doesn't he? Because remember, when it becomes systemic, it is most often an infectious process, not just inflammation. Okay? So once those bacteria and the white blood cells began to do battle in that wound, both of them released pyrogens. They went to his hypothalamus, and now he has what temperature problem besides infection and inflammation? He has a third one, which is fever. He has a fever, yeah. So what do we do for this person? What's the nursing interventions for this person? Say it loud. Antibiotics, yeah, the provider's going to need us to give him some antibiotics. Most likely starting with IV, but maybe because he doesn't have something internal, he may get to go home with just a script. We may give him an IM injection of an antibiotic and send him home with a script. What else? Might need an NSAID to help with some of that inflammation. Might be. Well, the NSAID could be used also for the benefit of antipyretic. Very, absolutely, good job. We need to clean that wound to remove as much of the bad guys as we can. We might even have to send a culture off to see exactly what's growing in there. Okay. You think of anything else? Yes, we may use a topical antibiotic. Sometimes physicians do, sometimes they don't. It depends on how that wound looks. Yes, we want to increase his oral fluids and make sure he has plenty of fluids so that the white blood cells have plenty to swim in as that fluid shift occurs with inflammation. Yeah, nutritional, absolutely. If he has any indication that he doesn't eat enough protein or B vitamins or zinc, vitamin C, all of those things that promote our immune system, we might need to provide him some suggestions or written information to help him with that. Anything else? Very good. It's too old to suture up after 2 days. Actually, after just a few hours, most physicians will not suture it up because we may give him an abscess inside. And so at this point now we have to let it heal slowly from the inside out. And so we're just going to provide teaching to teach him what to watch for. So what's the number one problem, or maybe 2 problems that we really didn't go into, but maybe life experience has taught you? What's the 2 problems that we want him to report, even if he goes home on antibiotics? Well, if the area does, she said if the area widens, which it might, but well, specifically if the inflammation travels where? Up the vessel. Okay, so if you see a red streak going towards the trunk of his body, then it's spreading from the area and we want him to come back. We may have to put him in the hospital and put him on IV antibiotics and have nurses watching that. The other thing is if it becomes purulent, if it begins to produce pus from that wound, we definitely want him back in there because the antibiotic might not be the correct one for what we're fighting. All right, there's one more. Let you do it on your own. I need to turn this back over to Mrs. Martinez.
Yes.
Thank you all.
Thank you.
You are still there, Mrs. Martinez?
Yes, I am.
Okay.
I guess I'll start with questions. Do you have any questions for me in Tukwila or Stillwater?
Interventions you consider with death and dying?
I could not hear that question. Was it about interventions?
For death.
Yes, she said, what kind of interventions would you consider with death and dying?
Okay. There were some slides that talked about, let's see, let me flip back to find the ones. They were, a lot of it is the slide, it's like the 10th or 11th one that has the role of the nurse. Has to do with providing emotional support and helping them to understand that anger is normal if that's present, encouraging the client to talk and listen, let them express their feelings. The pain management and symptom management is very important. Keeping their mouth clean, water if they want it, when they want it, food when they want it, if they want. Then I said, let's see, there's a slide called Common Nursing Problems. It says pain, anxiety, loneliness, so obviously trying to do some things to alleviate the anxiety, loneliness issues. Nursing care of families had to do with teaching them about what to expect. And that, a lot of times you initiate that with just asking them if they have any questions or concerns as you see death becoming imminent. And answering questions with your patient too, when they're still verbal, if they have any questions or concerns. So a lot of it has to do with being attentive to them, keeping them as comfortable with the positioning, preserving their dignity. Those are the kinds of things, and they're scattered throughout the slides pretty well. I said you care for that person just as if they're going to live. You're going to do all the things for them that you would do for any other client, as far as keeping them comfortable in their medications that they're on. If their doctor continues their medications for you, if they want to get up in the chair, by that time their activity is really up to them. Sometimes, they can ask suggestions. Would you like to sit up in the chair for a while and get closer to the window? Maybe you can see a little sunshine or something. Sometimes they think nobody will want to bother to do that. We'd be more than happy to do that. And their hygiene, again, keep their dignity and their self-worth as much as possible. Anything about rest and exercise?
Will there be like calculation questions on like the type of sleep, like when you're in certain like REM or anything like that?
We have a question on death and dying.
Okay.
Mrs. Martinez, on the nursing care of family slide where you talked about teach the family what they will see or feel, can you elaborate on that?
I was talking a little bit about the loss of muscle tone, so the mouth may gape open. They may hear those loud respirations. They can expect a decreased level of consciousness. those kinds of things. They may see the modeling, they may notice that the skin is getting colder, those types of things.
Okay, thank you.
Uh-huh. Let's see, Katie asked a question on rest and exercise. You said you were wanting to know about the sleep, about what, well, I didn't catch quite what
Like
you
know
said.
how to calculate like how long they're in REM if they're getting certain amount.
She was wondering about, you know, the difference between the 3 stages of sleep and then the fourth, really, the REM sleep, the rapid eye movement. If you would be expected to kind of break it down, like say they slept 7 hours, what's the likelihood, you know, how much time they spend in each, or, and that I would say no. I just say be aware that we need that stage 3 and that REM sleep to really take care of our brain as much as possible. And that's when our body kind of does its best restoration, and we have the release of growth hormones. That's why it's so important for children and adolescents, and they tend to be the ones who don't want to get enough sleep, the adolescents in particular. But that's when the growth hormones are released. So you might, you know, point out to them that if their REM, and of course it varies, it says about every 90 minutes and can last 5 to 30 minutes, but if it's only lasting 5 minutes, which we don't really know, I mean, we don't sit there with a flashlight and watch the rapid eye movement on our children. So we don't know how much REM sleep they're getting.
Maybe on the first kid.
Yeah, maybe the first kid, someone said, yeah, if you're really into things. But if they're getting less than 7 hours of sleep, they're probably not getting enough stage 3 and REM sleep. And your book says some people perform well, function well with less sleep. That's true. But if you think about, the likelihood that you're in that category of people who are really optimal with less than 7 to 8 hours of sleep, it's not that great. So look at it as, when you read through all those things about sleep deprivation and how we do not function at our optimal levels. And you don't have to be all that sleep deprived for it to affect you. If I get 6 hours a couple of nights in a row, I'm probably not at the top of my game that third day. In fact, I know I'm not. So think of it as that most people, when you do any teaching, is that with kids, because all of them want to be tall, they all want to be NBA players, tell them their growth hormone is released when they're asleep, and that if they don't get enough sleep, they don't get enough growth hormone. And then, with our adults, that life is hard enough when we're on top of our game. So if we short ourselves sleep, we really don't perform as well. And we're irritable, so we don't get along with people as well. Maybe, no, says you got 1 minute. Any more questions?
Yes, on sprains and strains, is it the treatment, are they both supposed to be rice and infants?
Strain, a sprain is. A strain, you might not do the compression. So not as likely on that. Because it's usually your back.
Rice and rye.
Rice and rye.
Rice and rye, one of my students said.
Rice and rye.
So,
That's how I remember it.
Yeah, I know.
thank you all for staying. I noticed that a lot of people left, so hopefully it benefits you.